Good evening. It's now 6 o'clock and I'm going to hand over to Dr. Hussain, who's going to facilitate this session. Thank you, Dr. Hussain. Over to you.
Thank you so much. I'm Dr. Akhtar Hussain, Acting Chairperson of South African Medical Association. And our webinar is today Unemployed Doctors and its Challenges. On behalf of South African Medical Association and the National Department of Health, a warm welcome to all medical doctors and the junior specialists and other distinguished healthcare professionals. Thank you for joining us. Tonight, we discuss a matter of great significance, the unemployment of medical doctors and specialists, especially post-com services doctors. The role of healthcare professional is undoubtedly crucial. And it is disheartening to acknowledge that increasingly number of qualified medical doctors, post-com service doctors, find themselves facing unemployment. In the pursuit of novel and selfless profession, medical doctors undergoing years of training, rigorous education, training, personal sacrifice. However, the current landscape suggests that despite their dedication and expertise, doctors are struggling to secure meaningful employment opportunity. This issue not only affects the individuals involved, but also has broader implications for our healthcare system, society, and overall well-being of our community and citizens of South Africa. It is my great pleasure to invite our first speaker from South African Medical Association Board of Directors, Dr. Theo Nodikita. Floor is yours, Theo.
Thank you very much, Dr. Hussain, and thank you to the colleagues who have joined here. Ladies and gentlemen, and esteemed guests, I'm connecting with you today with a very heavy heart. And I think what we are addressing here just goes beyond the medical community. It's got profound implications to the well-being of the people of our country. The South African Medical Association has identified this distressing situation, as indicated by Dr. Hussain, that just over 300 doctors in the summer survey found themselves unemployed post their community service. And what complicates this further is the fact that these doctors, some of them are actually bursary holders from different provinces across our country. And they've signed individual contracts with provinces to actually come back and serve in their communities. And these contracts are called social compacts, which means the commitment by government is not only with the individual doctors, but goes beyond just the individual doctor to the communities. And it is really disturbing and very distressing to find that these doctors now are out of work. The communities where they were providing these services are now without healthcare professionals who are trained. And in the main, they were servicing the outskirts and the rural areas of our country. So I think today, the purpose of today's webinar is to just look for solutions. And I'm glad that we have Dr. Percy Mahlati with us here today, so that we can look together, the Medical Association working with the department, to make sure that we find a solution out of this quagmire that we find ourselves in. And these solutions we can find in different ways. And I'm hopeful that Dr. Matlati will enlighten the discussions later on. And I must say, the other worrying factor is that there are various agencies, colleagues from outside of the country that are looking at these doctors. Immediately when we put our poster for this evening's webinars, the South African Medical Association received multiple requests from international agencies that are looking for these doctors. And it is our view that our communities need these doctors more than these other communities outside. But we really cannot have a situation where we have qualified medical doctors, where taxpayers' money was invested with the hope of getting a return on investment, and have these doctors working for the benefit of our societies, and we have them not doing that which they were trained to do. So I think, Dr. Hussein, I'm going to stop there for now, just to indicate the preparedness of the South African Medical Associations to join hands with government, especially the Department of Health. If needs be, we can have a joint letter to the Treasury and the Presidency, just to make sure that a stopgap financial measure is put in place to have the doctors appointed in the areas where they are mostly needed. I will stop there, Dr. Hussein, for now. Thank you very much for the opportunity.
Yeah, thank you so much, Dr. Nudikita. That was very insightful and your input. So we will discuss in next session. And then I like to introduce our next speaker, Dr. Zanele Bekicha, who is also, she's a board of director of South African Medical Association. Zanele, floor is yours. Thank you.
Afternoon.
Good afternoon.
Am I audible?
Yes, very loud, nice.
Oh, okay. No, thank you. I think it's a good thing that we have called this meeting, and I'm glad to see that we've managed to get, a large amount of the participants that we had been trying to reach, so that we could gauge how many doctors are affected by this. And I think it goes to show that as the South African Medical Association, we are willing, to be there and stand in arms with our doctors. And we worry about this on two fronts. We worry about it because not only is this affecting our members, we have doctors that don't know what is going to happen. We have doctors that are going to get their cars and homes repossessed. We have doctors whose families are relying on them as well. And that becomes a concern, because those are our members and that is the population that we have taken to serve. But it also comes to the second part, that as a South African Medical Association, we also are here to make sure that we are working for the interest of the health of the nation. And I think as the National Department of Health, as the South African Medical Association, we can both agree that this situation is not one that is tenable in making sure that we are providing the best healthcare services possible, particularly as we are saying that we are going forward toward NHI, which is going to make us need all professionals at all levels, at all areas, whether urban or rural. So it speaks to our readiness as a health system as well, and this poses a crisis. So I think it shows our willingness on those two fronts to be able to engage as the South African Medical Association, and not only to engage, but also to be here to find solutions. So on my front, colleagues, I'm Dr. Zanele Bekicha. I am a director of the Medical Association, but I also am employed in the public sector. I think some of the concerns that we have, and what I'm hoping that we're going to get a response from, we've seen the large numbers of doctors that are unemployed, but we also are aware that as much as Treasury has been saying that there's financial problems, we'll get to that part, but at a level of the Department of Health, how far have we gone into exhausting the internal mechanisms? I particularly would like a response to hear with the grants. There's the HIV grant, but now particularly taking an interest in the NHA grant. I'd want to know how have we utilized that to try and alleviate these problems that we're having in creating the budget to be able to fill these posts. I really am interested to know that how can we best utilize that so that these doctors at least are then able to be placed and be gainfully employed and servicing. So I really want to know at what level have our grants been utilized? Because we do have various grants beyond what is given to the departments. Like I'd mentioned, just the two, like your HIV and your NHI grant. Something as well that we are concerned about is the South African Medical Association. We know for a fact that every single time we come out and say there's unemployed doctors, we are almost always made to be seen to be hyping up the situation or over exaggerating it. And it either comes down to stats of how many posts are vacant, and it also comes to doctors being told that they don't want to work in rural areas. We know for a fact that there is an artificial lowering of vacancy rates within the Department of Health. And this is caused by their own internal mechanisms, where if posts are not filled for a certain amount of time, they then are considered vacant and they are then taken off the system so that they don't count to the vacancy rate. And only later get those posts, if you want, as per organogram, if you get your funding, you must reapply. Now, that becomes a concern to us as the South African Medical Association because it means hospitals that perhaps, let's say the organogram says that they need 30 doctors. You could find that due to the budgetary constraints, they have only been able to fill about 22 of those posts, meaning that 8 of those posts have now, for some time, now been taken off the system. And that does not stop the need for the full complement of those doctors in that hospital. So that becomes a concern. This artificial lowering of vacancy rates as per organogram becomes a problem for us because it means that we are further worsening the load that we are putting on doctors. We already know that as the South African Medical Association, we have been calling for a proper audit of our workload versus staff complement in the health sector. So that's also something that we want to raise now in this meeting to say we are aware that even with the vacancy rate, it is not a true reflection as per organogram and is more programmatic where you've got posts that actually go off the system if they are not filled for some time. So we have those concerns. We want answers as to how are the grants being mobilized to actually fill these posts of doctors, and then also to see that how is other hospitals being impacted that are now losing posts simply because they're unable to fill them because of budget, whereas they were determined to have needed them? And unfortunately, I feel the hospitals that are going to be most impacted are going to be the ones that we say we're trying to assist, those in the rural areas. So those are some of the concerns that we have here, and we're asking that we look into that now in the session with the Department of Health, that we look at mobilizing. And I think just to recap what Theo was saying, if we're going to then bring in the National Treasury, and I must say that we see the circular from National Treasury as nothing more of a silent moratorium. It's nothing less, nothing more. It's a silent moratorium. But we are willing, as the South African Medical Association, if deemed fit from this meeting, then willing to go up and sit down with Treasury and say that this needs to be sorted out. We need to make sure that funds are vied from different areas so that we're able to provide healthcare for the nation. We're heading towards a crisis. If we cannot even fill our normal posts that we've got obligations solutions for, then we cannot even begin to plan for specialist services. That will become another debate for another day, which the country will need, particularly going into NHI, looking at things like a certificate of need. So yeah, we are availing ourselves in this meeting, and I'm glad that we've got these doctors, and hopefully this platform is going to provide a way forward, looking into how we prevent this from happening again in 2024.
Thank you so much, Dr. Zanile Bikicha, for your very, very important inputs. And then we got our next speaker. I would like to invite Dr. Suzuki Maiwawa. He is also one of the board of director and past president of South African Medical Association. Dr. floor is yours.
Thanks, my legend. I think I don't have much to say except what Zanele already said. And yeah, so the issue is, like she said already, the Department of Health is actually playing games with us. When somebody resigns, they usually froze the posts so that it might look very artificial that there's no vacancies. And the other thing, what she said was the staff complement, especially for the rural hospitals. We cannot go on in that situation whereby we compromise our rural people, because at the end of the day, as much as you can talk a lot of English in this meeting, what's important is that our issue is the rural hospitals, where my mother is sitting. She cannot have access to a doctor because she's a rural person. And then the other thing was the grants. How do you employ doctors using grants? We cannot have that situation. And at the end of the day is the Department of Health plays marbles with us, and they always make numbers look like they are good. So, my legend, I see we've got a lot of people here who talk a lot of English. Can we be realistic and address a rural person in that Eastern Cape, in the rural area, to say what access do they have to a doctor? Well, okay, fine. It's not only doctors, also nurses, by the way. Because you cannot have a doctor without a nurse. So at the end of it all, I would say in closing, let's not play marbles, electioneering, and all those things. So at the end of the day is, can we have doctors and nurses in the rural areas? Thank you, my legend.
Thank you so much. Very, very important contribution by our past president as well. Now it's my pleasure and honor to invite and introduce our own Dr. Percy McLarty, the Deputy Director General of Human Resource, and our past Secretary General, SG of South African Medical Association. Now I will hand over the floor to our DDG. Thank you. Floor is yours.
Thank you. Thank you very much, Dr. Hussein. I hope that I'm audible. And thank you very much, colleagues, for the inputs that you have made. I'm going to approach it in two, ways. One, I think it would be important for me to react to some of the issues, but I think where one would wish to start is the second part of clarifying, how the management of our health system is structured, because I think that's very important. But first of all, let me just, thank Sama for having organized this webinar. I really would wish to congratulate you, because This actually goes to the heart of what was encapsulated in the founding principles of SAMA, where that tagline, Uniting Doctors for the Health of the Nation, came from. It did not mean that, we would be sweethearts to each other. It would forever. It would not mean that we would be fighting all the time, but clearly there would be creative tension, between our profession and, a health authority in the country, which would lead to a positive growth in our health system. I must say that I agree with Dr. Nodigita. Unemployment in this country is not limited to our profession. It's a serious government and societal problem. And that really needs to be tackled. But of course, we're in the health sector, we need to deal with that within the health sector and make sure that people that have chosen this profession as a future, a place where they would wish to spend the rest of their lives. The environment is conducive and all that, and it will not be conducive all the time. Now, let me come to the specific issues that have been raised. Let me deal with the one about, where I think Zianda spoke about the fight about the statistics. I can't remember who raised that, statistics and all that. Yes, I agree. We should not be fighting around statistics, but I saw on the Q&A somebody commenting that you've got 700 plus unemployed grade 1 medical officers. My interpretation would be saying then that those are people that have completed community service who are unemployed. It could also be those that, would have completed it before to gap year and all those kinds of things. I think the importance around these colleagues is that when these numbers are bandied around without detail, it makes it difficult sometimes to manage the situation. I'll give an example. One organization last year said they've got a list of 1,100 unemployed doctors. We requested details. They gave us their spreadsheet. It had multiple duplications of entries. There were people who were no longer, were interested in working for government, were in that list. There are others who had actually set up practice, who were actually put in that list as being unemployed. That is individuals who had set up their own practice. Now, when you get, data that is not properly cleaned up and made current, it becomes a challenge, because then the temptation, from the government side is, should we not go out in public and, expose this? But exposing that is not going to assist. We've had a similar thing this year where it has been said that there are 800 doctors who are unemployed. Unfortunately, some of the names of the people appearing in that name are unemployed. I think about 3 or 4 of them, I know it's a small number, have been employed since July last year, 2023, but they still appear on the list of unemployed. So what I'm trying to say then, colleagues, is that yes, let's not reduce it to a fight about numbers, but then when we make public pronouncements and say government is not doing its work, we've got so many people unemployed, let's be accurate about it. Because as the national department, our role is to coordinate policy. The provinces have to make sure that policy is implemented. Provinces are the primary employer. When we get this information, we then approach provinces and do the best that we can to squeeze their arms, to make sure that, where there is creation of posts where it is possible, bearing in mind that, where provinces work on budgets. One thing that I would concede on is that sometimes the synchronization of when, where community service officers, finish their community service year, and when new budgets kick in, there is a gap of about 3 months because the financial year starts 1st of April. However, that's not an excuse really, because there should have been, a planning, going forward for that. And that's something that we're working on with the coordination structures that we have between the national department and the provincial departments of health. In fact, yesterday and today we had a 2-day session where we met with the members of the National Human Resource Committee and members of the National Hospitals Coordinating Committee. I will come back later on to actually just share with you some of the issues that we're dealing with. So we do understand that post-community service is a difficult, situation. And unfortunately, the way things developed were not necessarily as they were planned. But if we were to go back to 2010, in fact, 2009, 2010, when the occupation-specific dispensation was crafted for I'll talk specifically for the medical profession. The plan was to make sure that there is a sizable gap in remuneration between community service year and grade 1 medical officer, accompanied by a number of posts that would have been created. The reason for that was to actually start building a career medical officer, layer. Because there are a number of colleagues who are not interested really in specializing, but they would like to actually be those career casualty service officers, and so on and so on. We're actually applying our minds around that. I will not go back and say what actually happened in the process that we lost that. But we're going back to that because we're definitely clear that if you've got a stable career medical officer category, linked together with a very stable nursing, categories that are relevant, especially primary health care, will be able to can turn around, the challenges that we have in the health system. So it's important for us to actually look at that. So it is not without, the planning aspect of it. We do know the internal challenges that have been faced both nationally and in the provinces. But some of the issues that we're actually dealing with, how do we deal with austerity? Colleagues, it's a reality that South Africa is struggling economically. Leading economists have said that and all that and all that. One thing that I think our minister had been pushing very hard on has been to say, in the midst of that austerity, is there a possibility that the frontline health workers can be spared, as much as possible, so that whatever the budget cuts are, at least they would not, be detrimental to us, employing people. But if you're going to employ more people, make sure that you've got good incentives to keep those that are in the system. Because it is no use to not keep those that are in the system, hoping that you are going to get new ones in. You want to retain the experience, the skill, the knowledge accumulated over years. I'm sure many colleagues would agree with me that, when you're fresh from internship or community service, there's still a lot that you actually have to learn, and you need those that have been in the system for quite some time to be able to learn even more the ropes. So it's important that we actually deal, with that. Part of what we're discussing yesterday and today actually relates to that. We've got a number of, retention incentives that were put in to plug the gaps over time. Your commuted overtime, your remunerative work outside public service, both of those that have become a serious problem. especially around commuted overtime being unaffordable, whether there were austerity measures or not. So we're actually forced to review those. It's important because no strategy is static. Always, when you come up with strategy, make sure that you revise those. So, we have put in mechanisms in place, and SAMA is one of those bodies that we are going to, engage, consult, and we are prepared, and we know that we are gonna exchange blows. But hopefully it would be blows that are very cushioned because all of us are working towards the same strategic objective. There are others that some of your colleagues, because we've indicated to you that there's been a review, should we continue with community service or not? There's been various, calls around a review of that particular policy. On one end, from the financial aspect, on the other end, where you actually get people saying that, why should I do this community service after internship? I'm ready and all that. So I think it's important, colleagues, that we all group together and say, how do we really manage this? Going forward. I agree with you, colleagues, the multiplicity of grants, because grants have got limited periods. You get a grant over the medium-term expenditure, a period, which would be about 3 years, on average. When that grant comes to an end, what then happens? And one colleague referred to the NHI grant. The National Health Insurance does not have a mandate to employ doctors. It doesn't. The mandate of the NHI is to purchase services on behalf of patients. It's unfortunate that sometimes we conflate, these issues. The National Health Insurance Scheme is being set up so that it could be able to pay for health services procured from service providers on behalf of patients. Health sector reform will continue whether there's NHI or not. So we should not then say, what we are doing, we are preparing for NHI as if NHI will be employing you. It won't be employing you. You'll still be employed by the province, by the agency that is there to employ. You'll still be employed in that particular hospital and all that. This is very important to make that distinction, because whatever mechanisms that we put in place, it's important that, where we view them from a number of areas. One, organizational structures must be responding to strategic demands on healthcare, which then means that your organizational structures must keep on being tweaked as we go along. Because also we know that of work is changing. If anything, COVID has taught us that. You will not need to be always in one place to be able to provide health services. But the question, how do we manage that? Because, example, there are colleagues that do commuted overtime. And overtime is a health demand-based, a mechanism. But we know some of the practices that have been a problem, that colleagues take overtime, especially 16 hours, to be part and parcel of their remuneration package. It's not. We've got to correct that. We know that is going to cause a lot of pain on many of our colleagues. Some of the colleagues would be at home but claim overtime, but they never set foot at the hospital or wherever they are supposed to be. They have not attended to emergencies and all those kinds of things, but claim that they were on call, that they were doing overtime. So these are some of the issues that we actually feel we've got to sit around the table and see, how do we really deal with that? One of the things that we've got to tackle, colleagues, is the overcrowding of our hospitals. What's causing that overcrowding? I fully agree with Dr. Mawea. That primary care environment, as long as it is not appropriately, resourced with expertise and experience, will continue the clogging of our, regional and tertiary hospitals. This is something that we've got to deal with. Bearing in mind also that the training platform is no longer at tertiary level. It's actually gone to regional and district hospitals and all that. And that is part and parcel of how we restructure our health system, especially the delivery part of it. I think the other one really is we are forced by circumstances. We should not have been forced by circumstances to review our retention measures. Because if you're going to have a multiplicity of retention measures that are actually colliding with each other, you're going to have a problem and you lose a lot of money in the process. RWAPS is actually one of those that we've got to actually address. I do know that there's lots of emotions around it and all that, but we're going to deal with it in a very professional manner, engaging with all the colleagues that are affected. Because it's not only about health service delivery, it's actually impacting even on training of our young specialists. It's impacting on supervision of the same interns and the community service doctors, especially interns. So there is a lot, colleagues, in the system that I think as the profession, we've got to take responsibility and say, how do we then, deal with that particular, challenge? Because if we don't, nature does not allow a vacuum. Somebody outside our profession will come in and impose, mechanisms that are actually going to be very, very difficult. Now, going towards, at the end of my input, I would like to say, colleagues, that there are certain prescripts that are public service-wide that get developed by DPSA. And we have to abide by those to the best of our ability. But I would agree with colleagues that it must not be to the detriment of the provision of health services. It must not be to the detriment of the growth of our, of our professions. We've just recently had to deal, and it took 3 years to address the matter that's very important to nursing, postgraduate diplomas, which are specialization in nursing. We had to actually, duel with the Council on Higher Education, Department of Higher Education and Training, and ensuring that our nursing colleges are up to standard to be able to train specialists in nursing. Because if you don't have theater nurses, ICU nurses, your specializations, what we used to call before cutting disciplines, are actually in big trouble. So it's important that we actually balance those. Fortunately, that has been resolved. Registrar training in the medical field is a serious problem. It has been raised by a few medical schools, and we're actually addressing that particular matter. I'm hoping that your registrar association is still there and is able to can actually, engage on those particular matters. Now, what we've got to do then is that our approach is to say, DPSA, you provide us with guidelines so that we can be able to comply with what is required for the broad public service. However, when it comes to what goes on in the health field, we basically become subject specialists so that we can be able to guide. So that's a very intricate relationship that we're working on. We're aware that there's been freezing of posts, but there is no post of a doctor, a nurse, any frontline health worker who provides health services. There is no there's no guidance that those should be frozen. Once somebody leaves that post, either through the resignation or unfortunate, a death and all that. But we do know that it's been reported that in some of the provinces, these things happen. And really would like those to be raised, with ourselves in the department so that we can be able to deal with those. Lastly, we've got structures in place. I refer to the National Human Resource Committee that is led and coordinated by Dr. Luvuyo Bayeni, who started in July last year. Then you've got the National Hospitals Coordinating Committee, which is coordinated by Dr. Lebohile Ncha, who also started work in July last year. And a lot of work is actually happening there. Both report to me. Those are chief directors that report to me. And we're open, colleagues. We're open to engage with you. And we really would like to address even other issues that may not be, even service related, but issues that would be more on conditions of service and all that, so that we are then able to be quite unified. You understand us, we understand you. So I go back to then what I started with earlier on. To extract value from the professionals that you employ in public service, it's important that there is a relationship of understanding between the two, that there is a relationship of trust, and we engage with honesty, so that when problems are picked up, you don't hear about them in the media first before they engage with us. But at least if we engage with each other on those issues, there's nothing stopping you going to the media, but you'll be going to the media knowing very well what the position or situation is for the department. It doesn't mean that people will not criticize, but people will criticize understanding fully what some of the challenges are on the other side. On the matter of actually approaching treasury and all that, I don't think there is any problem with it, but our own experience is that you approach treasury when you know that you've got irrefutable facts, you've done your research, and you are not going to get there and put an emotional argument. I don't want to speak ill of my colleagues at treasury, but if you then present emotional arguments to them, it's as if you actually never met with them. So I think it's important, colleagues, that we actually engage and have a very good strategic approach to the problems that we have. Yes, we're going to disagree on a number of areas. We'll spare, like in boxing, fighting each other, but not with the intention of damaging each other. It's important that the investment that has been made by the country in educating the young ones, we realize it by actually having them being absorbed, but the absorption capacity is limited. So we've got to find ways around it. The last one, which I know is not going to sit well with some of the colleagues, is that no country is able to employ every doctor that they have, because some doctors don't want to be employed by the state. But for those who are willing to be employed by the state, we'll do the best that we can to be able to employ them. Dr. Mawai, I would be very happy if you would have doctors who volunteer to go and work in those far-flung areas like Emangamzen in the Eastern Cape. I would be very happy. And also that we don't place junior doctors only there, that we have seniors to actually guide them. Because some of the challenges they have, even with this medical litigation that is gobbling up our budget, is because of the medical errors that could have been prevented were the seniors there in numbers and able to. But we don't want to get into a situation where there's finger pointing, but if you had done this, but if you did this and all that. I really appreciate, colleagues, the opportunity that you've given us as the Department of Health so that we could be able to engage with you. We sincerely hope that this is not the first and last that we engage on, that we'll be able to engage even behind closed doors on some of the issues, that were raised. There are many others that I could raise, but I will not actually deal with those now. So if I were to just, summarize, one, we've got to review the retention measures, because the more you retain, the more you attract people to come to you, rather than attracting and not retaining those who are there. Very important for us to do. We've got to really take into consideration the changing nature of work. Almost like what laparoscopic surgery did when it actually first came in. The major, value that we actually got that generally in health, strengthening of primary health care, because if we deal with that, we'll be able to assist the declogging of hospitals, we'll bring back the expertise into the public health sector so that you come in there, you've got to be seeing 60, 80 patients a day, every day. So there's many that we actually have to do. And let me end there, Dr. Hussein. I'm sure there will be a number of questions or issues raised in what I'm saying. And of course, we're trying to have all the energies to be able to address these issues. We cannot fold our arms or just throw our arms in the air and say, oh, look, there's so many problems, there's nothing we can do. We'll actually make sure that we start somewhere. We may not see the results now, but as time goes on, we'll be able to see those results. Thank you, and over to you, Dr. Hussein.
Thank you so much, Dr. Percy. You have given very important and very seriously the workplace issues, policy and program. And we will now move on into the question and answer session. But before I go there, you did mention about the OSD. DG, this OSD is more than 15 years old or 20 years. We're supposed to have a second phase of OSD discussion and planning. So that's the one issue we need to discuss. Retention strategy, you have mentioned, and COT review. I just wanted to know community service feature. Will they continue after 2-year internship, or is going to be some policy coming up that there are no more community service? DG, can you put some light on that?
Okay, that's fine. Let me start with the OSD review. You will recall that the OSD started in the health services. In health, we're the one to actually, develop that system, and deliberately started with nursing because, I thought that the features of my face are ingrained now, but I will continue.
Yeah.
The intention when OSD was implemented, we started with nursing intentionally. And some of the colleagues in the medical field were up in arms. It should be us, it should be us. We did so because we knew that unless you stabilize nursing, you'll kiss, your health services goodbye. But also, medical professionals had actually benefited in 1996, where there was a sizable increase in their salaries. Unfortunately, within 3 years, they were complaining that they are underpaid. So we do not want to make the mistake where nurses would feel that, it's only doctors that are important in the system. But also was that within a 3-year period, 3 to 5 years, there would have been a review so that we could be able to deal with the teething problems that were there. Unfortunately, I'm sure all of us know what the situation in the country, the instability, and all that. So that could not be done. For medical officers and others, it came in 2010, your allies came in 2010. Yes, you're correct. It has not been reviewed. I'm not sure whether you say second phase, you mean a review or not, because the planning was to review so that you can see whether the way it was applied was correct or not. Did it serve the purpose? And without revealing, what has been looked at, it's a mixed bag. Certainly, it managed to retain a lot of colleagues in the system. It managed to make sure that colleagues are well paid, even though they complain and say that they're not well paid. But if you were to make a comparison across comparable professions, they're well paid. But that's an argument for another day, which is actually why then RWAPs becomes a problem. That when you're actually paying, colleagues so well, but then you've got an unlimited, unmanaged RWAPs that actually takes time and money from the public sector to complement or supplement what, they are getting over and above, the OSD scales. DPSA contracted PwC, PricewaterhouseCoopers, to do a review of the OSD. I think they're about to complete that. There's been some engagement. There will be some engagement with us also in health, because we know that our health services are very, very, sensitive to even small changes. So we want to make sure that that review is not just done willy-nilly. We want to make sure that it addresses the big gaping holes that we have seen. Regarding community service, it's a mixed bag. We started with a review, but we cannot say whether it will continue or not. But if I were to paint a possible scenario, there are many hospitals, especially in the rural parts of our country, that if you were to withdraw that community service here, many of them, their services would collapse. So I guess that it could be easier to withdraw it with medical and dental professionals, but it would actually be a tragedy to withdraw it for your physiotherapists, your occupational therapists, your speech therapists, audiologists, and all that. Because that just 1 year of being employed means so much to those individuals and their families. Therefore, we cannot just tinker with that community service, a year, without taking into consideration the socio-economic impact of what we're doing. There are some of the NGOs that have, when they heard that there's thinking about it, they jumped up and said, you dare not do that. But it's important to always keep going back and actually look at the strategy or policy, whether it's serving the purpose. If it's not, where do we actually have to tinker and all that? I know some of you would say, why has government not been doing that for so many years? Well, the straight and simple answer to that is that we've not had central coordination leadership to be able to do that. Now we do have. The position I have is filled now, and the chief directors that are primarily responsible, around that, they are actually there, and they're doing a lot of work engaging, with colleagues. So I'm saying we do have a team now that would be able to, but it cannot do it alone. It's got to engage with very important groups like yours. I'm hoping that Dr. Hussein, I've managed to respond adequately to the two questions you raised.
No, thank you. DG, there are some questions on the Q&A. It's almost 28 questions, and you also look at those questions. I will raise few from from the beginning. One is, what are the number from the NUH perspective? How many unemployed doctors? Second one, ICSP should give us a rough picture of what is happening. In fact, communication-wise, the intern and com service doctors, there's always battle to get the information from ICSP. The third one, foreign qualified doctors to write board exam and should be placed for internship because they are waiting for a long. So I will take first three questions.
Okay, I got one on ICSP, one on foreign qualifiers. What was the first one?
First one, what is the number unemployed doctor from NUH perspective?
Okay, that's the easiest one to say. Unfortunately, we do not keep a database of unemployed doctors. I'll be upfront with you on that. Some colleagues, after finishing community service, decide that they will take a year off and not be employed. Others will leave public service and want to do locums around. So people do not actually, all that we can talk about are the people that apply looking for work, to say so many people this year applied looking for work. And those people and that number does not necessarily mean that is people that qualified only last year. Others are people that for whatever personal reason, we've had a number of people with personal reasons that decided that instead of starting work in January, they will want to start in July because of whatever personal reasons that would be. So I would be upfront and say that we don't have a database of unemployed, doctors. Because even if we had, when people then find employment in the private sector, the onus would be on them to inform us that, no, look, I've found employment now, take me off that database and all that. So if we've got to develop that database well, maybe we could, but they would actually have to agree as to what purpose it would serve. On the ICSP, yes, we do concede that there's been challenges around the ICSP. And more so that there's been a change in the service provider to actually run the system. There were some teething problems that have been sorted out. I would really concede that communication has been the weak point, because that's one part that I think we really need to beef up on so that we can be able to communicate. And also to be able to raise awareness on the colleagues that once the system gets opened, they actually need to apply immediately. But let me raise that one of the challenges that one of them I had to deal with it yesterday. You get colleagues that get, allocated. For the young colleagues, not everybody will actually find a community service post in Cape Town or in Johannesburg or in Durban. It's not possible. When we actually have got to place so many, those who have studied in our universities here and those who are coming, from outside, having finished, their internship, and we must place them. Part of the problem that we have is that people get allocated, then they want to actually make changes. Where to clamp on bad practice, where those that had the financial means get placed in an area where they don't like, and those who don't have financial means are placed, for example, let's say at the Somerset, a hospital somewhere there. The one who's got money placed somewhere in Limpopo will then buy so that they can swap between those two. I know that Sama is aware of that because those are the issues that have been raised. So there are challenges from either side, but I would say that the communication one really needs to be sorted out. The one on foreign qualified doctors, the mandate to make sure that we've got properly qualified, competent doctors is that, you know, where they've got to go through the HPCSA exams. And without the HPCSA providing us with a list of saying, these are so many that set for exams, these are so many that have actually qualified, it's difficult for us to just pick and choose. Yes, the issue of placement, they then get placed like any other, you know, that we actually have in the system. And we do know that there's been a delay in the exams because of the HPCA struggling to get a university that would be able to set and coordinate all those exams. Finally, UKZN came on board. The first part of those exams was done last year in October. The next one, I think, is coming up sometime in February. So I hope that I've tackled those three.
Yeah, thank you, DG. There are few hands I will take accordingly. I think Dr. Mayawa and Dr. Nikita, and then I will put two questions here. One question is, I'm very confused on how the fraudulent activities of COT does not speak the unemployment of doctors. And the other one, we already discussed accurate number of unemployment doctor. We already discussed that. If they are not frozen, the post, where the post then? Where are the posts then? That's the question. So I will ask first the hand raised, Dr. Mayawa and Dr. Nodikita, then these two answer.
Thanks, Legend. You know, Dr. Mahlati, you are one of us. You talk our language. That's why you are paralyzing me. And then you like, I'm really paralyzed because we invited, remember we invited him to come and talk in our last dinner that we had. Ne? So at the end of the day, he's really paralyzing me. But I would like to ask, so that from Sama's point of view, ne? He said, colleagues are paid very well, right? What do you mean by that? And then at the end of the, what do you mean by colleagues are paid very well? And then I agree with you, Doc, when you said NHI is not an employment agency. It will never absorb everybody. And there are doctors who out there, they don't want to be employed by government. That's the reality of it. I've worked for government for more than 20-something years. So is you. So at the end of the day, but when now you are preaching some language that you paralyzed me. You are like a priest. Because
come on.
You are one of us. So at the end of the day I ask myself, why did we invite a dog Pace? Because he talks our language, the legend. And then the other thing he said was the mixed bag of things. I think from some point of view, we have to be realistic with our doctors that the government cannot absorb everybody. That's what our president was saying. Government is not there to create jobs. It's there to make policies so that they must be conducive. I think he's quite aware of that. And then the other thing he said was organizational structure. I think our job as SAMA, we must go out there to educate our doctors, to say, what does it mean to be a doctor? My daughter is an attorney. Ne? She doesn't even know how a Z83 looks like. But our doctors think that when you finish medical school, the government owes you an appointment. I think that's where we are supposed to be starting to say, no government owes you anything. You must be able to say, how do I start from here? But Doc, you cannot answer those questions because right now you are talking from a preacher's point of view.
No.
You're one of us, honestly speaking. I remember we invited you. You talked to us for an hour, but that was good. Thank you.
Yeah, Dr. Hussein, I have a quick question, which I think.
Please come on.
Yeah, I wanted to redirect the webinar back to the main issue that we are here for, colleagues. I think for me, the most important thing that we must get out of this webinar is there is a real problem on the ground, Dr. Mahlati, that you've got junior doctors who were servicing a particular population in the rural areas of our country doing their ComServe. They are now post-ComServe, right? They are now post-ComServe and they don't have employment. So for them, it's almost it's a real life and it's a life and death issue for them. So I would like us to, I understand the technicalities and the budgeting things that relates to government, but I wish we could come out of this webinar with a concrete plan to say, and with time frames to say, what is it that we can do? A clear example is the fact that in the Eastern Cape, the doctors there, they will tell you that the circular that was written to them saying they will not be absorbed is a generic circular which speaks to all of them. But the contract they signed was an individual contract with the province, and it's a social contract. Now, this creates a problem for them when they are trying to get employment in other provinces, because they say, your province can actually recall you. Because in reality, that contract is not breached. So for me, I think I wish we can agree on steps that we can take jointly. Either the national talks to the provinces to say, look, either you withdraw and commit that you will appoint the doctors whenever your budget are loaded, or then we do the other thing of saying, these are the numbers from the Eastern Cape, these are the numbers from the KZN, these are the numbers from the provinces, and then we can go and talk and bid for funding, because I'm also certain that there's some money that might have been sent back by provinces that was not spent during the last financial year. So for me, I do want to redirect us to almost, because for the doctors, it's a painful thing that they are going through themselves and their families. Do we have, if we can develop a plan that addresses that, I would be very, very happy.
Thank you, Dr. Nurikita. Over to DG.
Yeah, first let me start with Dr. Maweya. Colleagues, I think it's very important for me to say this. I'm here representing the department, but the subject matter we're discussing falls under my portfolio. I must take responsibility. I cannot load it on anybody else because I'm accountable for what, is taking place. I mean, in there, like I have said, it's my responsibility to make sure that there is a team of both national and provincial that is able to tackle these issues. Like I had said, yesterday and today we're sitting addressing this particular matter. Now, honesty is very important, I said, people are well paid. And if I were to ask you, compare what interns, legal interns earn and what medical interns earn. I know that we're going to say, no, they're not in the same field, they're not doing the same work and all that. Besides that, let's just look at the basic salaries, that they earn. whether that interns in government or interns in private. So we start from there. Way back, I can't remember the year, as summer, we had a project of which was titled Looking at the Value of a Doctor. The only thing that I had serious challenges with it, with that, is that we then reduced it to a monetary value rather than an expansive, definition of what value is. Maybe it's something that, really we need to actually engage on as the profession, because I'm definitely sure that there is a lot that we would be able to learn as government from that particular process and would be able to actually work on. Coming to the issue that Dr. Nodigita raised of, the numbers. The Free State advertised on the 29th of December 60 medical officer posts. I think they'll be closing this week or next week, which then would mean that there would have to be, interviews done and all that, because applying does not automatically mean that you'll be employed. They actually have to look as to where the fit is, and all that. And I'll make some examples of medical officer posts that have been filled since October 2023. For instance, the Eastern Cape, the posts that have been filled, from October 2023 were 52. Posts that were advertised after October to date were 65. And those that are going to be advertised in the next 6 months are 49. So you've got 166, a number there. All this is actually tied to a budget. If I take Free State, you've got 150 in that, with that categorization. Gauteng, 575. KwaZulu-Natal, 277. We don't have the number for Limpopo because they've had to wrestle with their treasury to make sure that treasury is able to fund the requirements that they had actually put in. Limpopo, Mpumalanga, because of budget challenges and all that, and Northwest are in low numbers of 43 and 44 each, and Northern Cape 21. Western Cape 74. Now, Western Cape has absorbed a lot of professionals. What they've provided with us are those that they've advertised and those that they've filled, and those that are actually going to be advertising within the first 6 months. So in total, across the provinces, that is 1,178, posts. Those are the numbers that we're talking about. Now, I think what is important then, Dr. Nodigita, is that there has to be, some kind of eye kept, on those people that would have applied and not received, invitation for interviews, or those that, have been interviewed, but there is no feedback from the provinces for them. Because really, as the national department, we've got to take the responsibility to coordinate and make sure that our provincial colleagues do respond. You will remember, colleagues, that employment of doctors has been centralized provincially across all provinces to avoid a situation where people are employed in posts that are not budgeted for or maybe have not been approved. I will not mention the province, but we've had a situation where some people were employed. After 3 months, they were not, paid simply because they were appointed to posts that were not budgeted for. So we've made sure that we actually do away with that. But we will take responsibility if, on a monthly basis, Sama would be able to really assist us to know who of the people that have put in and there's been no response and all that, so that we can be able to put pressure on the provinces, hoping that they will actually be able to respond. Because remember that health is a concurrent function. We do not instruct provinces what to do, but they've got a responsibility and a mandate to really respond to, where the issues that are raised nationally. I'm hoping that I've dealt with those issues. The issue of frozen posts. Currently, we have a situation that if there is any administrative post that is required by the health, any department in government, there must be a formal request to the Minister of Public Service and Administration. That is excluding posts that are on the front line, that is posts of clinicians. So if there were posts that were frozen, there would be a process of unfreezing them. Unfortunately, if you freeze a post, to unfreeze it, you must actually get, a DPSA to concur and open that. They've got codes that they utilize for that. So that is why then our argument with Treasury and DPSA was to say, let's protect the posts that are on the front lines for clinicians, nurses, doctors, pharmacists, allied, and so on. I know that this freezing of posts is a historical matter, but we're hoping that from now, at least from about October last year, going forward, we will not have a situation where clinical services posts are frozen. But it's an issue that really needs to be guarded with a hawk's eye. Thank you, Dr. Hussein. Over to you.
Thank you, DG. Thank you very much. You have covered.
Thank you for the promotion. Thank you for the promotion.
DG. Sorry. The issue of unemployed doctor, we are really very much concerned, especially post-com service. We tried in a short notice, we did the survey, we submitted more plus 350 plus, and this survey is ongoing. And we tried to put Facebook, Instagram, and our group, webinar groups and other WhatsApp group. So we will collect as much as possible, but the problem is we will submit again. So the question, they are important question. So where are with the unemployment, and is there any plan for us, or for us means for the junior doctors or not? Is there any plan? Second one, currently have a problem. What is the way forward? What is the solution? We like to know. Can we have some timeline going forward? And I will handing over to you, DDG.
Thank you very much. I would make a request that as you compile that data that you receive, can you just make sure that when people respond, they respond with their numbers included, contact numbers, where they are, provinces where they are, whether there is any preference, where to work. It doesn't mean that where they prefer to work, that's where they will work. We've had individuals that had been looking for jobs for quite some time in the Eastern Cape, and they were not employed, and then we managed to get a position in Mpumalanga. People should be prepared to go and work there. Otherwise, if you want a position where you are, it's going to be impossible to do so. In that list, please, they must include their MP numbers, because we've got to check whether these are properly registered doctors. We know that we've got a serious problem of bogus doctors in the country. I don't think SAMA would allow that to happen. But please, let's actually get that, so that there is a proper MP number, ID number, PESAL number. Because if they've done internship and completed it successfully in this country, they would be having a personal number, which is a lifelong thing like your ID number. So it would be important for us to actually get that information, and please share it with us nationally. Because then what we will do is to make sure that we're engaged with. We've already asked provinces to actually look around for posts, where that would be open in the next month or 2 or 3 and all that, so that we can be able to, we can be able to place. As far as placing those that have completed internship and we're looking for community service posts, the information I have is that they have been placed. 694 of them were placed. There is a further, I think, 50-something or so number that is still being sorted out, and actually want to make sure that, those people are actually, placed. Now, you've asked a plan for junior doctors. I spoke earlier on about the review of the retention measures. We have to look at commuted overtime, colleagues. We spend a lot of money on that program. A lot of money that we could be able to utilize to employ more doctors if we were to do some modifications around it. I will not talk about details now because it's something that we're still working on costing, quite well. The second one is to improve on the planning side. If, let's say, Gauteng has supported, let's say, about 300, medical students. They finish, where they pass their 6th year, they go into internship. Clearly, by the time they finish medicine, undergraduate training, we know that in 2 years' time, they need a community service post. We know by the end of their 2 years of internship that 1 year on, they'll be actually wanting to be employed in public service, as many as they can. That is basically something that we're in discussion with Treasury about, to say we must have the ability to accommodate those that will actually be completing their community service in a year's time, so that by the time they finish, it is not a struggle to employ them as medical officers. That's one. The second one, I said, we're going back to the OSD to review and then find a mechanism of developing a career medical officer path, so that when you absorb those people, you absorb them with particular skills in mind that you actually want in the public service, so that we can be able to stabilize that particular layer. All that is going to require funding. But unfortunately, our economic performance as a country is not that good. So it's not something that I would promise that is definitely going to happen, but it's something that we're working on. Like I had said, we cannot plan for just 3 months. We must actually plan for the next 5-10 years coming, because whether we like it or not, medicine is not actually going to be done through robots. No matter how good artificial intelligence is, we're going to need human beings. More so if you look at the type of society that we have. So we've got to do long-term planning. I say all these, colleagues, not to preach like Dr. Mawe was accusing me of preaching. It's because we've learned from mistakes that have been committed in the past, and would actually want to, correct those. And like I said, with partners like, SAMA and others, assisting us in the process. Thanks, Dr. Hussein.
Thank you so much. DDG, we got a lot of questions also, but what we will do, we will hand it over to you, all those questions which we not managed to answer because of the timing, because there are a lot of questions coming up, and some of them will already answer. So as soon as you give us feedback, we will share with our member and those who wrote those questions. So thank you so much for job now to discuss. In conclusion, the issue of unemployment among the medical doctors is a matter that warrant our collective attention and concentrated effort. As we reflect on the challenge discussed today, it is imperative that we consider innovative solutions, advocate for systemic changes within our healthcare system. The dedication, expertise, and commitment demonstrated by our medical doctors and junior specialists should not be overshadowed by the unfortunate reality of unemployment. It is our responsibility as a society to create an environment that values and support those professionals by fostering collaboration.
My legend, can we give
Yes.
Zanele? She wants to say something as I saw her raising her hand.
Yeah, just a minute. By fostering collaborating between the healthcare institution, policymaker, and educational organization, we can work toward the implementing policies that address the root causes of doctors' unemployment. Together, we can build a healthcare landscape that not only values the expertise of medical professionals, but also ensure meaningful and sustained contribution to our society. Thank you for your engagement and commitment to this important cause and webinar today. I will, before I say good evening, I will ask our Dr. Zanele Bikija your input. Thank you.
Okay. No, thank you, Dr. Hussein. So what I wanted to say, because I think it's going to address the major question that's been in the group. We are going to work together to solve this issue of those that are unemployed. Can I ask that we get the details of those that have not submitted? And I think we need to dedicate ourselves as SAMA that within the next week, we are going to have this list cleaned up and sent to Dr. Matlati's office. And we are going to then follow up and make sure that all of these things are, all these people that qualify are attended to. So I don't want people to feel that they've wasted their time here. So if they can make sure that they send us, because I think we've got a list that has about 100 people, but in the seminar, there's more than that. Can they please submit their details? And we commit ourselves, Dr. Matlati, we're going to clean this list up and we're going to send it to you. And I'm glad that you committed that this is your office and you are going to be responsible for that, so that we then can deal with what is the problem and what brought us here today. The fact that there are unemployed doctors looking for jobs right here, right now.
Okay. No. Thank you so much, Dr. Zanele. So thank you very much, Dr. Pasi Matlati, the DDG Human Resource, and the South African Medical Association, and our office and your office will work together. And within a week, we will meet again and make sure all our unemployed junior doctors get placed somehow, somewhere. Thank you very much. Good evening. Thank you.
Thank you. Thank you very much. Good evening to all. Thank you, colleagues.
Thank you.